luckily we haven't covered too much other than the fact that what we do and what we diagnose in the mouth can often head off systemic diseases or other diseases within the body. So that's basically where we are. Dental caries and periodontal disease are infectious diseases. So we know that there are certain microorganisms that can cause both. Streptococcus mutans are dental caries, and then perio, we've got a whole gamut of bad bacteria that lead to perio disease. So this is very important for us, and we're frequently going to encounter these oral infections and diseases, and we need to be able to recognize those and identify their clinical significance to our patients. So some of the bacterial infections we're going to kind of go through here. One is impetigo. Some of you have maybe heard of this. This is very common in children. It is a bacterial skin infection caused by the Streptococcus pyogenes and Staphylococcus aureus bacteria. It commonly involves the perioral skin around the mouth on the face. This one requires non-intact skin for infection. So they need to have a break in the skin in some way for this to affect them. It is very contagious. So if one kid has it and they touch their mouth and then they're playing with other toys, this is passed in preschools and daycares pretty easily. The good thing is it can be treated with a topical or systemic antibiotic. Remember, all of these bacterial infections can be treated with antibiotics. So often people will, they'll have a child that's sick with the flu or whatever they think it may be, and they want an antibiotic. We've kind of steered away from that because we build up an intolerance, or a tolerance, I guess I should say, to the antibiotic where it no longer works for that patient. And really, if you've got a virus, your antibiotic isn't going to do anything other than maybe fend off a bacterial infection due to your being weak at that time because you're already sick with a virus. Here's an image of what that impetigo looks like. Tonsillitis and pharyngitis. These are inflammatory conditions of your tonsils as well as the pharyngeal mucosa that surrounds your whole throat back there. Sore throat, fever, enlarged tonsils, redness of that mucosa in the oropharyngeal area and tonsils. This can be spread by contact with infectious nasal or oral secretions. And it is that group A, B hemolytic streptococci. This can also be associated with the scarlet fever and rheumatic fever, this bacteria. So that's something to remember about that one. I like this picture because it shows us the diseases of the mouth and throat. So the first one is a healthy throat. And then the next one is showing kind of the redness from pharyngitis. Then we see tonsillitis. You can see the tonsils back there that are inflamed. The uvula looks a little angry. Then we see diphtheria, which luckily we don't see that too much anymore, where it's kind of white on the tonsils. And then you see the fungal infection on the tongue and the soft palate of the last image. So those are kind of, I like that picture just because it kind of shows them all. Okay, if I can get this to change, there we go. Bacterial tonsillitis will affect the uvula. You can see the tonsils, and they get those deep tonsil stones is what a lot of people refer to those, where those deep crypts fill with bacteria, and they look kind of white. The gray furry tongue is also common. I don't know if I shared with you guys, but I worked with a gal that would get these all the time, and she would like dig them out and want everyone to smell them, which is really disgusting. But she would come in the morning and she would get the suction out and would take the suction back on her throat and try to suck these stones off of her tonsils. It was incredibly nasty. But anyway, when you're in dentistry, let me just tell you that people share everything more than you ever wanted to know or smell, for sure. Fever is a condition caused by this bacteria, and it usually occurs in children. With this, obviously, we see fever, and we also see this red skin rash. That's why it's called scarlet fever, and it's due to a toxin that is released by the bacteria that caused the condition. The oral manifestations of this condition are little red petechiae on the soft palate, and sometimes they'll call it strawberry tongue, where the patient's tongue gets super red. And those fungiform papilla are red and very prominent, kind of like the seeds on a strawberry. And this is kind of what it looks like if you can kind of see why they gave it the name. And then the rash that you see on this child's arms and their torso is how it gets that name of scarlet fever. Rheumatic fever is important to us because rheumatic fever can cause heart valve damage. And back in the days of pre-medication, we pre-medicated every patient that had a history of rheumatic fever. There are certain guidelines that the American Heart Association has us follow now, and we are no longer just across the board pre-medicating everyone. There has to be a specific defect with that valve or a congenital deformity before pre-medication is recommended. However, we do at our school, and we did in private practice. If a patient had been pre-medicated by their physician and the physician insists that the patient be pre-medicated, we always default to what the doctor or surgeon or whatever they recommend. But we get that recommendation and usually have some sort of consent from them before we proceed. Rheumatic fever is a childhood disease that follows with this group AB hemolytic streptococcal bacteria. And what it is it's just an inflammatory reaction that occurs in the heart and the joints, as well as the central nervous system. And they've shown that it has caused lasting damage to heart valves. So sometimes it may require pre-medication. These are some of the images just kind of showing what a patient that's suffering with rheumatic heart fever might look like. That's what their throat would look like. And then if you look at the valve damage due to the disease, it almost always affected the left side of the heart valves. And you can see the mitral valve on the lower picture, how tightly closed it is, or sclerosed. So that makes blood flow difficult for these patients, and in many cases this valve would be replaced. Okay, another bacterial infection is tuberculosis. This is caused by the organism Mycobacterium tuberculosis, which is nice because it matches the condition. Not all of them do. The chief form of this disease is a primary infection of the lung. So that's where we're going to see tuberculosis most of the time. And many times these patients will have an ongoing chronic cough. Rarely do we see these oral ulcerations, but if we do, they're very painful. You can see it in his tongue there. It is a non-healing, slowly enlarging ulcer. They can get pretty ugly. The signs and symptoms are the fever, chills, fatigue, persistent cough, just overall malaise and weight loss. If we see tuberculosis that is spread widespread through the body, they call that miliary. And if we see it in the submandibular and cervical lymph nodes, that is scrofula tuberculosis lymphadentitis. To biopsy this, we need, or if they have the oral lesions, we're going to biopsy it, and we're going to see chronic granulomatous lesions with necrosis, lots of macrophages and multinucleated cells, as well as lymphocytes. And when you guys have to go get your TB test, they inject under your tissue, under that top layer, that purified protein derivative, or a PPD, and they evaluate it 48 hours later for a reaction. If it's raised and indurated or anything like that, then we know we've got a positive reaction. If you end up with a positive PPD test, that does not mean that you have tuberculosis. It means that you've been exposed to tuberculosis or you've had it possibly in the past. So if you would get a PPD positive reaction after that 48 hours, they would then send you for chest radiographs to look at the lungs and evaluate the lungs then to see if you do have active tuberculosis or if they can see scarring from past tuberculosis. With tuberculosis, an interesting thing is we've seen an increase in the number of TB cases recently, not recently, but in the last few years. And that's due to this resistance to standard drug regimens. So people can no longer, the drugs are no longer working, which makes them more susceptible to these TB cases, or to TB. They think it could be related to the HIV infection and the increased immigration from countries where TB has been endemic. It's also considered an occupationally transmitted disease in dentistry. Obviously, if we have a patient with active TB, we're not going to treat them. This would be similar to COVID. You would need to have a respirator and things like that. If you were going to treat somebody that had active TB, you would want to take every possible precaution, and the only way we would treat them is in an emergent situation. Because standard precautions could still prevent transmission of this disease because it's highly contagious. Routine treatment can be deferred in patients like this. So a use of a special mask, like I said, to prevent transmission would be imperative in this case. The combination of medications, and I don't know if you guys have talked about any of these in pharmacology yet, but they use isoniazid, rifampin, rifapentine, and many times this treatment goes on for months. It's not something you just take for a couple weeks and you're good. They take this medication for months or even years. The patient's physician should be consulted to determine whether that patient has been declared no longer infectious or not before treatment is performed on them. Another bacterial infection is actinomycosis. We're going to talk about they're deep fungal infections that end with SIS. Don't confuse this one. This is actually a bacterial infection, and it's caused by a filamentous bacterium called Actinomyces israeli. The key to this one I have highlighted in red, and they are little abscesses that you can see there on the face and like kind of under the chin, and they drain, and the exudate that comes from this, they call them little sulfur granules, and what they look like to me is bright yellow pieces of rice. The treatment for this is long-term high doses of antibiotics in order to heal the situation. Syphilis is another bacterial infection that we're going to talk about. It's caused by the spirochete Treponema pallidum. These organisms will die when exposed to air and also changes in temperature, but they are transmitted by direct contact, sexual contact, transfusion of infected blood to a fetus from an infected mother. So that's called congenital syphilis, when a baby is born with syphilis due to mom passing that to infant. There are 3 different stages. There's the primary stage, and people pronounce this different all the time. You can call it a chancre or you can call it a canker. It just depends on the person. I'm going to say chancre, and it is the first oral lesion that we see in the primary stage of syphilis. The secondary stage is a mucus patch, and then oftentimes if people didn't receive treatment, it would go into a latent stage where you don't see anything. So a lot of times I guess people thought they were good, you know, especially back in the day, and this was kind of a well-known condition back in the day. but nobody wanted to admit it because it was a sexually transmitted disease. So when the little mucus patches would go away, they would just think that it was gone and it was fine, but it could come back years later in the tertiary stage and it can be deadly. Syphilis can go through the palate and actually eat up, I mean, for lack of better terms, it would go up into the brain. And they would say that these people were crazy because it would affect them, obviously, if it's, eating a hole up through the palate into the brain. So syphilis is nothing to mess with, and it's easily cured. It's highly infectious. So like I said, these first pictures that we're looking at are pictures of that chancre. And I would think that if you had a lesion such as this on your lip or your tongue, you might be concerned, I would hope. It would also be accompanied by lymphadenopathy, so you would have swelling of the lymph glands as well. The secondary stage are those mucus patches that you can see on this tongue. They appear as multiple and they're painless, kind of a grayish white plaque that covers ulcerated mucosa. This is the stage when syphilis is the most infectious. They undergo spontaneous remission, but may recur for months or years. And then, like I said, that tertiary stage is a guma. And this is a palate that you're looking at that is a hole. It is a firm mass sometimes that then kind of becomes quite destructive. At this point, the patient is non-infectious, but that lesion can result in perforation of the palatal bone and involve the central nervous system as well as the vascular system. And it occurs for years after the initial infection if the patient doesn't get treatment. Congenital syphilis, like I said, is that Treponema pallidum can cross the placenta and enter the fetal circulation. This can cause serious, irreversible damage to a child. Facial abnormalities, they can be blind, deaf, or paralyzed. The dental abnormalities that we see are enamel hypoplasia, Hutchinson incisors, which are corkscrew-shaped looking incisors, as well as mulberry molars. And the first image here is pointing to those Hutchinson incisors. And then the mulberry molars look like lots of little berries rather than your normal occlusal grooves. It looks like little round berries all over the occlusal surface of the molars. So diagnosis of syphilis, the skin lesions can be identified by dark field microscopy. And the blood tests include the VDRL, which is Venereal Disease Research Laboratory test. There's also a fluorescent treponemal antibody absorption test. The treatment is penicillin. And if a patient is allergic to penicillin, they can use another antibiotic, but penicillin is the treatment of choice for syphilis, and it's very easily treated. The next condition we're going to talk about is NUG, and I know we've talked about this before, and I'm sure you have other classes as well. This is probably something you will come in contact with. This is very, very painful. Gingiva is very red. There's necrosis of the interdental papilla. Sometimes they'll call it cratering of those papilla. They'll get almost kind of a gray pseudomembrane covering on them. And because all of this is like dying tissue, it smells horrible. They'll call it a fetid odor. And that is due to the fusiform bacillus bacteria and spirochete, the Borrelia vincenti. And this is associated with a decreased resistance to infection. So we see NUG in patients that are compromised. We see NUG in patients that are stressed. College students are often ones that they associate with this condition because they're not sleeping, they're not eating right, they're holding weird hours and not taking care of themselves. So people like that will end up with this condition. The diagnosis is that necrosis resulting in the cratering, the sloughing of that tissue can cause that pseudomembrane that I said over the tissue. And how are we going to treat this? Well, you can't go right in. Many times the infection is going to fight your anesthesia. So we're going to do a gentle debridement. If possible, I would probably try to use my Cavitron and just gently debride the area. If the patient has a fever, an antibiotic might be necessary. And they oftentimes will recommend hydrogen peroxide rinses, and then we'll bring the patient back like in a week or so, and then go back in and retreat that area. We did have one patient that came to our clinic that was in so much pain. And honestly, you could smell the odor all over the clinic. It was, when you've got somebody with NUG. And she was in so much pain that she just wanted us to treat. So we got her numb, and we did one half of her mouth, and then we let her go to lunch, and she came back a couple hours later, and we did the other half of her mouth all in one day. And then she came back to us in a week, and she was so grateful. Not every patient can go through that. She wanted to. She was so miserable. But typically we'll do a gentle debridement, have them do some rinses, and then bring them back when we've got things under control. The other thing, if we apply our nutrition educational information, we know that we've got, in order to get this to heal and to get them to respond, they've got to change their diet. We've got to get them, if they can't eat because of the pain, we've got to get them either doing some liquid nutrition, so that they're getting enough protein and enough of the vitamins that they need to heal. Or we've got it, they can mix together. They call it magic mouthwash that contains lidocaine, I think milk of magnesia, something else that kind of coats and numbs the mouth so that the patient can eat. So there's things that we can do for the patient in order to get their nutrition under control as well. Pericornitis, you guys see this every day, probably, or many times. This is that inflammation around that, typically the third molar on the lower. Now, if we're calling it pericornitis, it's inflamed, it's infected, and it gets that way because it traps stuff underneath there, and it sustains trauma from chewing. So if we're talking about just a flap over that back tooth that's not infected, that's an operculum. But once it gets inflamed and red and angry, we're going to call it pericornitis. And that lower third molar is the most common location for this. Treatment is to mechanically debride. A lot of times I would lay my Cavitron in there just gently and kind of flush and irrigate the pocket, as well as kind of try to move out any lodged food or materia alba or popcorn holes or whatever it might be that had gotten stuck in there. Antibiotics can help with this if it's really bad. And often the long-term solution is removal of the tooth, removal of the third molar. They can actually go in and clip that operculum too. It often grows back, but it can be removed. Acute osteomyelitis is an acute inflammation of bone or bone marrow. This most commonly is the result of the extension of a periapical abscess. So this patient started out with an abscess, and it was allowed to become quite involved before they received treatment. It can also often follow a fracture of a bone and may result from bacteremia that has been allowed to follow that fracture or from that abscess. The diagnosis is going to be non-viable bone. It looks really bad. Necrotic debris, acute inflammation. Treatment is going to be to drain any exudate and get that patient on antibiotics. And then chronic osteomyelitis, the one we were just talking about, is acute. So that's quicker onset. This is a long-standing inflammation of bone. So the involved bone is painful and swollen. Radiographs will reveal a diffuse radiolucency. And if it's been there a long time, it can actually become more opaque. And it is also known as chronic sclerosing osteomyelitis when we start to see that opacity develop on radiograph. Treatment of the chronic type is going to be debridement, administration of systemic antibiotics, and some patients may require hyperbaric oxygen treatment in order to get that bone to regenerate. I just saw that Alasia had a question about the hydrogen peroxide rinses. Yes, I would think that would sting a little bit. It's going to bubble in those areas of infection. And typically we just have them only do that for that week, like between when we debride and then when we return, have them come back for a full cleaning. Okay, now we're going to talk about fungal infections, which you guys are pretty familiar with, candidiasis. So what is candidiasis? It is the overgrowth of that Candida albicans fungus. It can result from a lot of things: antibiotic treatment, cancer chemotherapy, corticosteroid therapy, which in the conditions we were talking about last week, corticosteroids were the drug of choice. So any of those conditions could end up with candidiasis. Dentures, diabetes, HIV, infants get it. So I'm trying to think. I think it's called thrush. I don't know why it was hard for me to come up with that, but in babies it's often called thrush. Dry mouth leads to this as well. The types of oral candidiasis that we might see are pseudomembranous, erythematous, denture stomatitis, chronic hyperplastic, and angular cheilitis. The pseudomembranous candidiasis is a white curd-like material present on mucosal surfaces. You can see it on the palette here. And underneath that white material is very red. So if you wipe that off, that tissue looks really red. This patient might complain of a burning sensation or a metallic taste in their mouth. Erythematous candidiasis. This is just a red lesion that's painful. It can be localized to a certain spot, or it could be generalized throughout. You could see irregular patchy depapillation of their tongue as well. Denture stomatitis is also known as chronic atrophic candidiasis. This is the most common type. Now, if they take their denture out, this is what you see. You see like bright red outline of where that denture has been. And it's usually limited to just that mucosa that's covered by the full or partial denture. Most commonly seen on the palate and the maxillary alveolar ridges. The funny thing is it looks very painful, but usually is completely asymptomatic. We see this in patients that do not remove their dentures at night and don't soak them. They're not cleaning them enough, and that fungus is building up on there, and that tissue isn't getting a break. It's not receiving oxygenation. So we always want to recommend that patients take those out at the very least, like while they shower, put them in a little dish of, a denture soak that's antibacterial and antifungal and all that stuff, so that we are killing that bacteria and fungus. Brush it, get it really clean. Even if they're just giving that tissue an hour to not have that denture on it, it's going to help. This is the most disgusting picture, I think. This is chronic hyperplastic candidiasis. It's also known as candidal leukoplakia. You're going to hear it probably most often called chronic hyperplastic candidiasis. This is the only one that, when it's the white lesion that does not wipe off. So if you took a piece of gauze, which is always the first thing I do with a white lesion, because I want to rule out a fungal infection before I start thinking leukoplakia, which could then make me start thinking of cancer or something bad. So I always take a piece of gauze and try to wipe it off. If it doesn't wipe off, then I'm going to call it leukoplakia until I know what it is. In this particular case, this won't wipe off, and it does, but it will respond to an antifungal medication, which would be a therapeutic diagnosis. So, a doctor may take a look at a patient with this condition and No, it doesn't wipe off, but it really doesn't look like hairy leukoplakia. It really looks like Candida. So we're going to try an antifungal first, which is easy. They would just prescribe nystatin, give it a week, and see what happens. If it doesn't respond, then you could send it for biopsy. But at least we would rule out the fact that it was not Candida, which is an easy fix. And then angular cheilitis, we see this a lot with denture wearers. My daughter wears a retainer at night, and that causes her to kind of drool. And in the corner of your mouth, if it's exposed to a lot of moisture, a lot of times that fungus can grow there, and it causes this angular cheilitis. It could also be caused, as you guys know, by B vitamin deficiencies. So a couple different things that could lead to that. Chronic mucocutaneous candidiasis is a severe form. This is usually only going to be seen in patients that are severely immunocompromised. They're going to exhibit chronic oral fungal infections, as well as genital mucosal infections and skin lesions. So that would be someone who's really, really immunocompromised. Median rhomboid glossitis is very similar to geographic tongue, only there is the thought that this is associated with the Candida fungus. We have seen this on occasion on patients that are on long-term antibiotics. They build up, it messes with the flora in the mouth, and it leads to this condition. The difference between median rhomboid glossitis and geographic tongue is location. Geographic tongue moves around the tongue and can also be seen on gingiva as well. Median rhomboid glossitis is typically a red rhomboid shaped area that is flattened and smooth, and it's usually found kind of right at that midline on the tongue. So that's how you would differentiate. How would we know if it was Candida? Again, we're going to treat it with antifungal treatment and see if we can get some resolution. It could be, it's just going through the diagnosis and treatment on this next slide. A mucosal smear could be obtained and sent to a laboratory for exam. In some cases, this candidiasis is persistent and recurrent and could possibly be a sign of an underlying medical condition. Deep fungal infections. Now remember, we talked about actinomycoses that had the sulfur granules out the little swelling on the face on that patient. That was a bacterial infection, and I told you not to confuse it with these deep fungal infections that end in SIS as well. They're completely different. The oral lesions that can be caused from these deep fungal infections, but most of these, the primary location are going to be in the lungs. So these are very difficult to say. We've got histoplasmosis, coccidioidomycosis, blastomycosis, and cryptococcosis. Okay, you get the idea. Anyway, these are going to be primarily found deep within the lungs, and the infections that caused these conditions are organisms that are more common in certain areas of the United States. So you'll see these conditions will be usually localized to the area where these organisms live. Histoplasmosis, the fungus that causes that is often due to bird dung. So I had a patient that had histoplasmosis and he grew up out on a farm, and I think they had lots of ducks and geese and things like that. So he was often working around bird dung, and whatever that contains, you can breathe that in through the soil and everything that's in the air. And I think he had only 1/4 of his lung functioning due to the damage from this infection. So that's just kind of an example of what these deep fungal infections can cause and where they come from. The diagnosis is made by a biopsy or microscopic examination of that tissue. The oral lesions are usually, like I said, preceded by the lung problem. And then the oral lesions are going to become chronic and non-healing ulcers. They can also resemble squamous cell carcinoma because they can be pretty severe. Here is a deep fungal infection. You can see on that palette, that lesion, how bad that is. So you could possibly, you'd see that and you might think squamous cell carcinoma. I would definitely be getting them to an oral pathologist for sure. Treatment is going to be systemic antifungal meds such as amphotericin B, ketoconazole, or itraconazole. Latent infections may remain after treatment, and they could reappear if the patient becomes immunocompromised in some way. Mucormycosis is a rare fungal infection. This organism is commonly found in soil. It's usually non-pathogenic. We see this sometimes with diabetic or debilitated patients, and it can present as a proliferating or destructive mass in the maxilla. It could involve the nasal cavity, the sinus, and hard palate. The diagnosis, again, is made with biopsy and identification of these specific organisms. Okay, so now we're going to talk about viruses. The human papilloma virus infection, the HPV, we hear a lot about that in today's world. There's more than 130 types of HPV that have been identified. Some of the common ones are Verruca vulgaris, Condyloma acuminatum, and focal epithelial hyperplasia. Verruca vulgaris is the common wart. It is usually a white papillary exophytic lesion. Exophytic means outward growing, so it sticks out like, usually they're pedunculated, usually they kind of have like a stem. And papillary, to me, I think of it looking like a cluster of teeny tiny grapes. So if you look at a wart really closely, you can see how it has all those little papillary projections and it sticks out. It's often transmitted from skin to oral mucosa. So people, let's say I have a wart on my finger and I start chewing on my fingers, you can pass that then to the oral cavity. And that's called autoinoculation. And again, this common wart closely resembles a papilloma. A papilloma is another oral lesion that we'll talk about, but they closely resemble one another. It is a common wart is diagnosed by biopsy or a histologic exam. Conservative surgical excision is usually done. The lesion, as you know, warts can come back. Patients with finger lesions should refrain from sucking them or biting their fingernails to prevent that autoinoculation. Condyloma acuminatum is a benign papillary lesion caused by HPV. It's a bulbous pink mass. It can occur anywhere in the mouth on the oral mucosa, and we might see multiple lesions. The thing to remember with condyloma acuminatum is it is generally transmitted by sexual contact. It could be transmitted through the oral to the oral cavity through oral genital contact or self-inoculation. And if we saw this condition in a child, it would be strongly suggestive of sexual abuse because it's transmitted by sexual contact. So that would raise a red flag immediately. And this is what it looks like. If you can see this lesion on the lip there, it's pretty similar to the color of oral mucosa, but a raised lesion. And again, you could see multiple. Diagnosis is made by a biopsy and identification of the organisms in the tissue, and treatment is going to be conservative surgical excision. When we do that, recurrence is common in this, kind of like with warts. Okay, multifocal epithelial hyperplasia is also known as Hex disease. Now, if you look at Hex disease, this could look very similar to condyloma acuminatum. So you would definitely want to get a biopsy and get it diagnosed, especially if you found this in a child. The only difference is this Hex disease is a little bit lighter in color. It's white to pale pink nodules throughout the oral mucosa, and we do most commonly see this in children. It is generally asymptomatic and does not require treatment, and it will spontaneously resolve in a few weeks. The herpes simplex infection, again, another virus. There are two forms of herpes. Type 1 is the oral, and type 2 are genital. Herpes simplex is one of the viruses that are human herpes virus, HHV. You'll hear it. We hear HPV for human papilloma. We hear HHV for herpes, human herpes viruses. Just so you know what they might call this. Primary herpetic gingivostomatitis is that initial infection that a patient gets. If you've never had herpes before, that initial infection can be really bad. It is most common for this to occur in a child ages 6 months to 6 years old. But I can't remember if I've shared with you guys or not, but this happened to me in college. I hadn't had a cold sore. I'd never had herpes. And when I was in college for Halloween, we all dressed up, and my girlfriends and I dressed up like babies and wore, footy pajamas, thought it was super cute. We all had our little bottles that we were drinking our drinks out of, and people would take our bottle and drink out of our bottle. And that is how I contracted herpes the first time. And I was home for 2 weeks. I had the worst lesions in my mouth. I had a fever. I was completely fatigued, slept nonstop, couldn't eat a thing. It was horrible. So it doesn't only happen in kiddos 6 years and under. It happened to me at 18. So again, you've got painful red swollen gingival, lots of tiny vesicles. It was down my throat. It was on my gingiva. It was everywhere. So just so you know, that's the first, the primary exposure to herpes. Then we can have recurrent herpes. So the virus persists in a latent stage. It's like the gift that keeps on giving. Now I have herpes in my system, but it's there in a latent stage. It usually sits in our nerve tissue in that trigeminal ganglion. 1/3 to half of the population of the United States will experience recurrent herpes simplex infection. The most common location for recurrent infection is on the lips, the herpes labialis. Those can be brought on by stress, sunlight, your period, fatigue, fever. Any of those things can bring it on. I've even had, they talk about canker sores and things being brought on by acidic foods. If I do something like that, even sometimes it'll trigger the herpes virus on my lips. This occurs, we know herpes because it occurs intraorally on keratinized tissue that is attached to bone. So if we see a lesion that's covering like the hard palate or on the gingiva over the alveolar bone, that's probably herpes. And if you see it on movable mucosa or non-keratinized mucosa, that's probably an aphthous ulcer. Recurrent herpes can be present with, it has those prodromal symptoms. You'll have pain and tingling and burning, like I can feel it when they're coming on. The highest amount of virus is in that vesicle stage. So when that pustule pops up and you can see that's when the most virus is present. The thing to remember about this is it's very contagious. It's transmitted by direct contact with an infected individual, and you can cause this by self-inoculation. So it's very important not to be touching your sores and rubbing your eyes. Using a washcloth on your face and over your mouth, and then using it on other private areas of your body. You could transfer this from oral to genital. You could transfer it from oral to eye. So you've got to be really, really careful with herpes. Herpetic whitlow is a painful infection of the fingers caused by a primary or secondary infection of herpes. Before we wore gloves routinely in dentistry, a lot of dental workers would end up with herpetic whitlow because we'd be in their mouths working around, and maybe you'd have a cut on your finger and they've got a herpes lesion, and now you have probably contracted herpes. So we don't see that too much anymore because we all wear gloves and we're very careful. But we want to be really careful. And just so you guys know, in our clinic, I've gone to a few oral path continuing eds, and they no longer recommend. They used to say if it was dried and crusted that it was fine to go ahead and treat the patient, but we do not, and they recommend not treating them at any stage of the herpes virus because of the horrible things that can happen to your eyes. If you're creating an aerosol and they have virus, whether it's a high amount in the vesicle stage or a low amount in the crusted stage, it could still fly and get in their eyes, your eyes. So we don't treat herpes lesions at any stage in our clinic. We would reappoint them for a couple of weeks later. Okay, so diagnosis of herpes is based on that clinical appearance and the changes that we see in the epithelial cells microscopically. Treatment would be antiviral drugs. So I take acyclovir every single day because I have it so severely. My lips would be a constant swelling of herpetic lesion if I didn't take them. So I take that on a regular basis, just kind of as a prophylactic measure. But if a patient developed it, they would put them on an antiviral when appropriate, when it flares. Drugs have not been shown to be consistently effective in treating the lesions except in immunocompromised patients. So it doesn't immediately make it go away. It can help. And then there's also, I can't think of the name of it, the cream that you can put on it that they say reduces the length of time by a couple days and helps with pain. Varicella zoster is chicken pox. Chicken pox is the varicella component of this virus, and then the zoster is shingles. We see chicken pox in kiddos. We see shingles occur in adults. So transmission with this is respiratory aerosols, contact with secretions from those skin lesions. Very contagious. This has an incubation period of 2 weeks. Incubation period is different from prodromal. Prodromal is that tingling that we get with herpes a couple days before. Incubation means I've been exposed and now I'm carrying this virus for a couple weeks before my body actually shows the symptoms. Recovery from these is 2 to 3 weeks. The secondary chicken pox in an adult is that shingles, and it can take longer than 2 weeks. My mom had this unilateral, it usually follows that trigeminal nerve. We only see it typically on one side. It's very painful, eruption of vesicles along that sensory nerve. Any branch of that trigeminal nerve could be involved if lesions affect the face. The vesicles are often preceded by pain and burning and often paresthesia. Disease usually lasts for several weeks, and neuralgia, that the pain that comes in that nerve after, can take months to resolve. The pain that my mom felt was so bad she couldn't even have a sheet on her legs. Yes, Abreva. Thank you, Taylor Terrell. Okay, so varicella generally is treated with supportive care. Antiviral drugs might be used for an immunocompromised patient, but it's really not going to do a lot of good with shingles. Shingles just has to work its route. What do I want to say? Just kind of has to go through the whole system. You can't really do much about it, unfortunately. Is just supportive care, anything to make the patient feel more comfortable. In some patients, corticosteroids have been used in an attempt to prevent the pain. from that post-herpetic neuralgia that can develop. I'm looking up the clinic number. Yep, that's it. You got it. Thank you, Taylor. Okay, Epstein-Barr virus is associated with infectious mononucleosis, nasopharyngeal carcinoma, Burkitt lymphoma, and hairy leukoplakia. Characterized by sore throat, fever, swollen lymph glands, the enlarged spleen, malaise, extreme malaise, fatigue, and petechiae may appear on the palate as well. It's primarily seen in adolescents and young adults. It's often called the kissing disease because it's transmitted through saliva. This is what it might look like in the throat of a patient with mono. We also see the redness on their hands. Epstein-Barr virus is also associated with hairy leukoplakia, which we see in HIV patients. This is just that irregular corrugated lesion that we see on the lateral border of the tongue. That also, the side of my tongue looks like that just from trauma. So we need to have more information. And if you see a patient with something like this that's ongoing, and their history doesn't give you any reason to think hairy leukoplakia, you might start, it could be due to friction from the posterior teeth too. Coxsackie virus is another one. This is transmitted by fecal to oral contamination, saliva, respiratory droplets. There's 3 distinctive oral lesions that are associated with this virus. There's herp angina, which looks a lot like herpes, but it's not herpes. Hand, foot, mouth, which we see in kiddos. You guys have probably heard of that. And acute lymphonodular pharyngitis. Here's herp angina. This patient's going to experience fever and malaise, sore throat. They're going to have difficulty swallowing, little tiny vesicles on the soft palate, red throat. That usually resolves in less than a week without treatment. Most of these viruses, they just have to kind of resolve on their own. The hand, foot, mouth disease often occurs in children under the age of 5, and we're going to see multiple macules or papules on their skin of the feet, hands, toes, and fingers, hence hand, foot, mouth disease. The oral lesions are painful vesicles that can occur anywhere in the mouth, and again, this is going to spontaneously resolve in 2 weeks. Adults can get this too, and it's pretty painful. The lesions on the feet, I had a couple students that ended up with this. One of the gals' little kiddos had it, and she gave it to one of her peers, and it was pretty painful, and they were out for a little bit. This is what the lesions may look like. You guys, it's 12:30, and I know that we are typically done at 12:30. I'm going to continue on. If you have somewhere that you need to be, you're fine to duck out, and this is recorded. So I will place the recording out on my YouTube and give you the link as soon as I can. The acute lymphonodular pharyngitis is also characterized by fever, sore throat, mild headache, the hyperplastic or enlarged lymph tissue of the soft palate or tonsillar pillars. This lasts several days to a couple weeks, and again, no treatment. We've just got to let it run its course. And this is what it looks like. And other viral infections that may have oral manifestations are measles and mumps. Measles and mumps are both caused by the paramyxovirus, and both are highly contagious. With measles, we'll see systemic symptoms and a skin rash. The Koplik spots are what are associated with measles, and they are little red macules. These can even occur in the oral cavity as well as on the body. With mumps, this is, they always say chipmunks, because it's an infection of the salivary glands, and the patients get this bilateral swelling of their parotid glands, so their cheeks puff out. Here's measles. This little child has the little complex spots on his face and body as well as in the mouth. And here's a man exhibiting mumps. You can see the swelling where his parotid gland is. HIV is another virus, obviously, transmitted by sexual contact with an infected person. You could also contract this by contact with infected blood and blood products. Moms can pass it to their infants as well. HIV affects the cells of our immune system. So the CD4 T helper cells, which is going to affect our immunity, so it's going to compromise us. Those T helper lymphocytes participate in cell-mediated immunity and regulate our immune response. So if we have a decrease in the number of those cells, then we do not have the ability to fight. So that's kind of what happens in these patients. There's a spectrum of HIV. Many individuals will experience the acute disease shortly after they're infected with HIV. Others remain asymptomatic and may not have symptoms for a long, long time. Most patients experience a progressive immunodeficiency where it just kind of progressively worsens. And as the immune system becomes deficient, life-threatening opportunistic infections and cancers can occur. So opportunistic infections are the body is no longer able to fight. I mean, we're exposed to stuff all the time and our body is able to fight it. Our immune system fights it. But when we get to the point that we're compromised, now the things that we normally would be able to fend off with no problem, our body can't. So anything that comes in our body causes an infection. It can also lead to cancers. The spectrum of HIV. We've got an exposure to HIV, and we can either have no infection or an infection. Some people that have infection will end up with the acute or quick onset disease. Others will have lymphadenopathy and be asymptomatic. Then it can go on to become more involved, where we have laboratory abnormalities and different signs and symptoms that are associated with the condition, and then those opportunistic diseases. And then it can, after a number of years, it can become full-blown AIDS. So the current definition of AIDS is an HIV infection with severe CD4 T lymphocyte depletion. So that's fewer than 200 CD4 T lymphocytes per microliter of blood, where the normal level should be between 550 and 1,000. So these patients have a severe deficiency of those T lymphocytes, the CD4. Two antibody tests that are used are the ELISA, which is an enzyme-linked immunosorbent assay. That one is done first. If a patient tests positive to HIV 2 times with this ELISA test, they will then do a Western blot test to confirm. The clinical manifestations of AIDS are that initial infection. Like I said, it could be asymptomatic. Some may develop that lymphadenopathy, and others develop an acute illness that resembles mono that lasts, a week to 2 weeks. After an acute illness, some may have persistent lymphadenopathy, and many can become completely asymptomatic. So that's what's scary about some of these viruses, is you don't know that you have them. They're just sitting there, ready to be shared. HIV infects the cells of the immune system, specifically those CD4 T helper cells. The immune system then becomes deficient, and then you get what AIDS-related complex, where you have an occurrence of several signs and symptoms together. These patients will exhibit oral candidiasis, fatigue, often weight loss, as well as that lymphadenopathy. The antibodies to HIV usually become detectable about 6 weeks after an infection. In some people, the antibodies may not be detectable for 6 months or even up to a year or longer. And that is called the window of infectivity. So in some cases, patients don't even know. The spectrum of HIV infection includes an asymptomatic infection to a full-blown AIDS condition. HIV stands for human immunodeficiency virus, and AIDS is the acquired immunodeficiency syndrome. Medical management of AIDS. There is a polymerase chain reaction test which measures the amount of that HIV in the serum, the amount of virus that's present in that patient's blood serum. This is called the viral load. Whoops. And the viral load, along with the CD4 T lymphocyte count, is used to assess the HIV infection in that particular patient. And they now are managing this with a combination of antiretroviral drugs and drugs that have been used to treat opportunistic infections. Treatment of AIDS has come a long way, and Dr. Thurlow usually has a guest speaker come and speak on that, and it's really amazing to me. It's no longer a death sentence. People are living long lives with AIDS. There are many oral manifestations of AIDS that we need to be aware of. They are associated not only with AIDS, but also the virus, just the HIV. Some lesions can indicate a developing immunodeficiency and predict AIDS in HIV positive patients. The oral lesions develop due to a deficiency in those T helper cells, the CD4, and they include opportunistic infections, like we said, tumors, and even autoimmune-like diseases. Here is a whole list of those. I'll let you look through the oral manifestation list. Oral candidiasis, we talked about, is that fungal infection that we often see with AIDS patients, and HIV positive as well. Herpes can be seen with these patients as well. Herpes zoster follows the usual pattern when it occurs in a person who is HIV positive, so that's shingles. They are still going to follow those branches of the trigeminal nerve in the facial and oral regions. This is a sign of developing immunodeficiency in that patient. Hairy leukoplakia, again, remember, caused by that Epstein-Barr virus that also causes mononucleosis. Hairy leukoplakia is a good predictor of AIDS in an HIV positive individual. Chronic tongue chewing and hyperplastic candidiasis can resemble this, and there is no treatment for it. HPV is also associated with these patients, which could be associated with their antiretroviral treatment. Kaposi sarcoma is that opportunistic neoplasm that occurs in HIV patients, typically located on the palate and gingiva, and it is a cancer, so surgical excision can be done and radiation treatment. Lymphoma, another malignant tumor that can be associated with HIV, and again, that would require chemo. Gingival and periodontal disease are often present in these patients. We're going to see that linear gingival erythema, the redness along the margins. We might see NUP, necrotizing ulcerative periodontitis, which occurs after NUG. So these patients need to be seen on a regular basis to keep their gingival health under control and their periodontal health under control. The redness along the margin of the gums, in what that looks like is just very spontaneous bleeding in those patients, petechia-like lesions on the attached gingiva and alveolar mucosa, and just that band of redness along the gingiva that will not respond to therapy usually. And the NUP, again, extreme rapid bone loss, redness. So treatment for these patients is going to be scaling, root planing, soft tissue curettage when necessary, lavage or irrigation. Chlorhexidine mouth rinses can be helpful, and systemic metronidazole for fungal infections. The spontaneous gingival bleeding could be due to that decrease in platelets that we see with these patients. We see aphthous ulcers and sometimes salivary gland disease as well. And that is a wrap. For those of you that are still here, thank you for waiting. And for the rest of you, have a great day. And I will put this out on YouTube.